Hello and welcome to the training module on osmolality testing, in-house versus sending out. At a high level, in-house testing provides a number of benefits that one should keep in mind when selling against the perceptions that sending out meets the needs of a laboratory and their healthcare providers. The key benefits include faster turnaround time, as sending testing out can take 24, 48, or even 72 hours to complete, cutting into the window that the physician has to use the information to make the best treatment decision. Specimen integrity, because when you manage your patient specimens in-house, you ensure they're properly used and stored according to the laboratory protocol. The ability to perform stat testing, because no send-out testing is truly stat. Although reference laboratories do offer priority testing, this requires the need to acquire and pay a courier to deliver outside of the regular pickup schedule, which, along with the added testing urgency, adds to the cost per test. Even then, the transport and processing of your specimens adds precious time to the turnaround time of your results. Additionally, in-house testing tends to be less expensive, so a case can be made around cost savings per each test and capital expenditure justification. Something that is also inherent in how laboratories make the decision to keep testing in-house versus sending it out is test reimbursement. Although it is important to be aware of this decision factor, it is a topic that should be approached with some delicacy from a legal standpoint and is not appropriate for use as a selling point. So why is turnaround time so important for osmolality testing? Primarily, turnaround time is considered most critical for conditions like hyponatremia, diabetes insipidus, and toxic alcohol poisoning. For hyponatremia, measured osmolality provides information to nephrologists that blood sodium measurements and subsequently calculated osmolality can't provide. Namely, the measured osmolality can clue the nephrologist in on differentiating true hyponatremia from pseudohyponatremia, which influences two totally different treatment decisions. Measured osmolality testing for patients with diabetes insipidus requires hourly testing over a period of 6 hours, making in-house testing a critical resource for that test. For toxic alcohol poisoning, the osmolality measurement is critical in informing the presence of toxic alcohol in the patient and is considered a SAT test for emergency medicine providers. First, let's focus on hyponatremia. For hyponatremia, the differentiation between true hyponatremia and pseudohyponatremia is something that requires close attention, as the failure to perform a measured osmolality test promptly can delay an appropriate treatment decision. The most common cause of the pseudohyponatremia is hypertriglyceridemia, or severely elevated cholesterol in the patient's blood, typically secondary to lifestyle factors or certain medications. Watch the video to learn more about how an extended turnaround time for osmolality can lead to a failure in adequately identifying pseudohyponatremia and potentially lead to mistreatment and readmission.
So there are a number of different ways that this can impact the hospital. The first part, obviously, is if you're delayed in making a diagnosis, that can lead to prolonged hospital stay. Somebody who has to wait for 48 hours to make a diagnosis of pseudohyponatremia or a alcohol ingestion, for example, will end up with longer stay in hospital to actually manage these conditions once they're properly identified. But also, there's a significant risk of readmission to the hospital in cases where patients have been misdiagnosed. I can remember one particular case a number of years ago of a patient who presented with severe hyponatremia. Sodium was 114, did not have a serum osmolality measured during her initial admission, and was treated as a severe SIADH from her pre-existing cancer. And she was discharged from hospital on a very strict food restriction and on sodium tablets, and returned a week later with similar hyponatremia and severe dehydration. And at that point, a serum osmolality was checked, and it turned out that it was normal. And the diagnosis in this case was Gleevec-induced hypercholesterolemia that had caused a false lowering of her serum sodium concentration. And so not only did she spend 4 or 5 days in hospital the first time around correcting a sodium that was not low in the first place, but she also ended up being readmitted a week later and spent another week in hospital subsequent to this, recovering from the treatment that she'd been inappropriately prescribed. And so that is a real world impact to not having access to the testing on site.
Diabetes insipidus, a condition where your kidneys lack the tools needed to appropriately concentrate urine, leading to several symptoms, is another disease that requires the timely monitoring of osmolality. During what is called a water deprivation test, nephrologists rely on serial osmolality testing on both urine and serum every 1 to 2 hours for a duration of anywhere between 6 to 8 hours. If the urine osmolality exceeds a 600 milliosmol kg threshold, the disease can be ruled out. However, if the urine osmolality remains under a 400 milliosmol kg threshold with an elevated serum osmolality, this indicates a likely diagnosis of diabetes insipidus. Watch the video below to understand why the timing of the serial osmolality tests are so critical in accurately informing this diagnosis.
Just another simple example is a test that we do in patients who have suspected diabetes insipidus, where we do serial testings of the urine and serum osmolality over a period of about 6 hours. And these are patients who have the potential to become extremely dehydrated extremely quickly because of urine losses. And so we need to know what the serum osmolality is doing and what the urine osmolality is doing very accurately in order to both diagnose these patients, but also make sure that we're not over dehydrating them in the setting of this test. And so this would be an hourly testing of this serum osmolality and urine osmolality. And if we didn't have that on site, it wouldn't be possible to do the test at all and make this diagnosis. And so not just acutely, but just in simple diagnostic terms, it's very important to have this ready access on site.
Arguably, the most powerful case for stat testing of measured osmolality is that of toxic alcohol ingestion. Because toxic alcohol poisoning results from the ingestion of substances that could lead to permanent organ damage, timing is everything. The risk of toxic alcohol ingestion can be assessed by subtracting the value obtained for the calculated osmolality from the value obtained for the measured osmolality, which is called the Osmolal Gap. If the gap between the two results is greater than 10 milliosmoles per kg, this supports a diagnosis of toxic alcohol ingestion.
And the reality is that there are two problems with this. One is that there are issues that can falsely change the sodium concentration, both raise it and lower it. And also there are other osmoles that may be present in the serum that you're not going to measure if you just use a calculated osmolality. And in certain cases, this can be directly harmful to the patient. It can be dangerous. If you do have a toxic alcohol in the blood and you don't realize it early enough, then that can lead to permanent damage or even death in patients who have a severe ingestion. And so without the idea that a calculated osmolality can substitute for a measured osmolality just is not borne out in clinical practice. And I would argue against anybody who would make that assumption.
All of the clinical implications considered, what are the perceptions that we're selling the value of in-house osmolality testing against? The first is calculated osmolality. Calculated using various other analyte results that can be run on any standard chemistry analyzer. So sodium, urea, and glucose are all factored into that calculation. The perception here is that calculated osmolality provides physicians with everything they need to safely make clinical decisions. Unfortunately, calculated osmolality fails to measure certain osmotically active substances like mannitol or toxic alcohols. Additionally, the sodium measurement that makes up part of the calculation can be falsely lowered in lipemic specimens. The second is urgency. Some labs fail to recognize the utility of rapid turnaround time for osmolality testing. The perception here is that osmolality is not and is never considered a stat test, and labs can afford the extended time to result for send-out testing. Unfortunately, in certain cases, like for water deprivation testing and toxic alcohol poisoning, in-house testing is critical. Delayed testing for the investigation of toxic alcohol poisoning could lead to mistreatment, organ damage, and even death. So how do we get the conversation started around bringing testing in-house? First, start by asking your laboratory partners questions that identify gaps in information needed by their providers to guide the appropriate treatment of their patients in the context of the conditions we covered in this module. For the first question, this could potentially uncover a knowledge gap around the utility of this testing to influence life-saving treatment decisions for patients who have ingested toxic alcohols. For the second question, this could potentially identify gaps in the lab's ability to accommodate water deprivation testing for diabetes insipidus. For the third and fourth questions, these could help initiate a broader discussion around cost savings, return on investment, and result delays. So what are the key takeaways for this module? The first is that in-house testing is generally faster, less expensive, and more controlled than send-out testing, where you're at the mercy of the high-throughput laboratory timeline and courier integrity. The second is that certain conditions require access to information on a more accelerated timeline, making send-out testing inadequate when meeting the turnaround time expectation to aid in the diagnosis of hyponatremia, diabetes insipidus, and toxic alcohol ingestion. The third is that diabetes insipidus diagnosis, by way of water deprivation testing, requires urine and serum osmolality testing every hour for 6 to 8 hours. The fourth is that the investigation of toxic alcohol ingestion requires immediate testing to rule out the presence of toxic alcohols in the blood and avoid chronic or life-threatening consequences. And the fifth is that calculated osmolality does not account for all factors influencing the osmolality measurement, including the presence of toxic alcohols and hypertriglyceridemia.